Paula Davis, and I'm the Assistant Vice Chancellor for Diversity for the School of the Health Sciences. I want to welcome you to our Pride Month iteration of Diversity in Practice, our speaker series. And our speaker today is Dr. Michael Marshall. And you know how you have those happy coincidences where you happen to bump into someone and think, I've needed to know you for so long. I felt that when I met Dr. Marshall at actually the first of our PUSLA gatherings. We have a new LGBT affiliate group for Pitt and UPMC. And when he told me what he does, I thought, awesome, we definitely need to have you for a speaker series. And he agreed. We were very, very appreciative. Dr. Marshall is Assistant Professor of Psychiatry and Pediatrics here at Pitt and UPMC and a licensed clinical psychologist working in adolescent medicine at Children's Hospital. And he's been studying psychosocial risk and protective factors for adolescent substance abuse and LGBT youth for over 15 years. So he's going to talk with us today about the state of the literature for mental health issues for LGBT adolescents.
Thank you very much. And I felt the same way when I saw you. Good connections to have. Hi, everybody. Thank you very much for coming. So yes, this is taking stock of an emerging literature, and I coined it this way because it really is young literature, as you'll see in a few minutes as we go through the slides. I want to say thanks to the PUSLA steering committee, who's sort of helped me sort of establish a presence at Pitt in terms of doing research in this arena. And I also want to thank the National Institute of Drug Abuse because they're funding all of the research that you're about to see today. And without them, I would not have a job, so I'm very grateful for them. These are the goals of the study, or of the talk. We're going to talk briefly about common definitions of sexual orientation, theoretical mechanisms of LGBT youth mental health disparities, detecting, explaining, and reducing disparities, and some conclusions and reasons for hope. You can ignore the last bullet. We're not going to talk about cognitive behavioral therapy today. So the first couple of slides I'd like to just discuss, how do we define homosexuality? How do we know if someone is gay? In the social sciences literature, what do we do to capture this population of people when we're trying to understand whether or not they're at risk? We think of this as being measured on three continuums. Whether or not someone has same-sex attraction, whether or not someone is engaged in same-sex romantic or sexual behavior, and the last one is whether or not someone is identifying as gay or lesbian or bisexual. They're all three very interesting and somewhat distinct for various reasons. The top one is one we use in the adolescent medicine clinic a lot. When teenagers come into the clinic, we don't ask them if they're gay or bi or lesbian, because a lot of teenagers aren't identifying that. We say, we ask them as part of our routine clinical interviews, are you romantically or sexually attracted to girls, both, or not sure? Excuse me, girls, boys, both, or not sure. Every kid gets this question because we want to know more about their romantic and sexual lives, especially as it pertains to their long-term health and what we can do to help them stay healthy and happy. Behavior is interesting because in the public health world, they do a lot of research on HIV transmission in public health. And the highest risk group for HIV are men who have sex with men. And so this term MSM, or men who have sex with men, emerged from that literature because it's a behavior that one engages in when they contract HIV. So behavior is specific to public health more often than not. And identity is an interesting variable because when we look at group differences between LGBT folks and heterosexual folks in terms of mental health outcomes or substance abuse, we find the biggest differences when we're using measures of identity. We don't know why. It's kind of an interesting scientific question that we're trying to unpack. We think it's very important to think about sexual orientation as being on a continuum. And I think it's important to recognize that, forgive my colloquial language here, I think we all kind of assume that risk for mental health problems increases as one's sort of gayness increases, right? further you are on the continuum, close to being 100% gay and lesbian, the higher risk you are. But that's not the case, actually, as we'll see over the next several slides. In fact, we find that bisexual, mostly heterosexual folks, exhibit much higher rates of mental health and substance use problems than do folks who identify as 100% lesbian and gay. So that complicates things from a research standpoint, but it's also an interesting sort of social and personal phenomenon, I think. How many gay people are there in the world? How many gay youth are there in the world? This is a hard number to estimate, as you can probably imagine. But when we use traditional measures of asking people what their sexual orientation is, we come up with about 3 to 5% of the population. We ask people, are you straight, bisexual, or gay? Gay, lesbian. And this is what we get. But if we include the mostly heterosexual group, those numbers change dramatically. And we know that most of the folks who identify as mostly heterosexual are at much higher risk than some of the other groups. So it's important to continue to include them in our counts, in our continuum. The numbers double. So we have approximately 10% of youth would identify as one of these groups, as being part of one of these groups. And that doubling of that number has a big impact on the research that we do and all the public health implications down the line. It essentially doubles public health care costs for LGBT folks who are high risk for substance use and mental health problems. So we're going to, I think, Kinsey, 50 or 60 years ago, maybe 70 years ago now, came up with this 10% rule, and he was right based on the data that we have. A national representative sample of teenagers, we got this 10% number. So how many gay youth are there in the world? Just as a rough guesstimate, obviously we're going to be off by a few. If there's approximately 1.2 billion children who've reached puberty in the world, this means that there may be about 120 million gay youth worldwide. That's a pretty big number. That's a third of the size of the United States. What about the United States? So I got this number from childstats.gov. I don't know why they use 314 as a denominator. I think it's actually up to 360 now or so is the United States population. I'm not sure, 360 million. And they estimate 25 million teenagers in the United States, which means there's approximately 2.5 million sexual minority youth or gay and lesbian teenagers in the United States. So 2.5 million is a big number. I think Allegheny County is 1.2 million. So we're talking about twice the size of Allegheny. I raise this because I think sometimes folks think that, well, it's such a small group of folks, it's not going to have a big impact on public health costs. Why should we care? You know, we'll just let that slide. But in fact, we have good reasons to care. If it was one kid or 120 million, we should care. This is the primary theoretical framework that we use to describe why LGBT folks might be at higher risk for mental health and substance use problems. And it's really quite simple. It's really hard to be a member of the LGBT community living in a very homophobic and violent society. There's a lot of stress that goes along with being gay. It can be just hearing people on the playground, calling each other fag, or it can be blatant, violent behaviors towards you by your father, by someone at school on the playground, or otherwise. We're going to see some of that data in a minute. But keep this in the back of your mind as we go through the rest of the slides. These are the sources of stress that I just came up with off the top of my head that gay youth may be experiencing. And I think we're not far off base, and I'm sure we could think of a lot more. But just think about government levels of stress or discrimination. Gay youth, they're not dumb, they're online, they know what's going on. They know that when they meet their lifetime partner and they want to get married, they can't, right? According to the federal government. So gay youth also oftentimes are rejected by fundamentalist type churches who condemn and chastise people for being gay and say that it's a sin and kids are going to burn in hell. So when mom and dad force Johnny to go to church every Sunday, and he has to listen to his pastor tell him that he's going to burn in hell because of who he is, how he was born, that can be stressful. Here's one of those boxes that I want to highlight and talk about in a little bit more detail. So I'm going to go off on a few tangents, so bear with me. My 10-year-old daughter, Camille, is finishing her last day of 4th grade today. And she is a powerhouse intellectual kid. She is reading at the college level, and her math scores are 2 or 3 grades above her 4th grade level. And she finished the whole Harry Potter series before age 8. And the last 3 or 4 books are 750 pages long. I barely got through them myself. She's a dynamo. And she said she wants to be either a corporate lawyer, so she can make $1,000 an hour, or a kindergarten teacher. And so I'm voting for the latter myself, because I think she'd be much more fun to hang around. Do you think that Camille's going to run up against sexism in the corporate world? You bet. And she has a mom and a grandmother and an aunt who she can go to for advice. What did you do when you were discriminated against? When you experienced sexism, right? My son Diego is also off the charts. But he's probably the only kid in the Fox Chapel School District with a Spanish name. Is he going to get discriminated against in Fox Chapel for having brown skin? Most likely so. Who is he going to talk to about it? He can talk with his mom, he can talk with his grandma Lupi, he can talk with some of his cousins. What did you do? You were discriminated. But gay kids don't have that luxury. Most gay youth don't have gay parents. So in addition to all of the stressors the gay youth have, they have a dearth of resources. And even in the best circumstances, when parents know that their child is gay and they love them and they're accepting and they want to help them move forward, they might not have had the same kinds of experiences themselves. So they are at a loss, and I see this frequently in clinical psychology realm when I'm working with teens and their families. The parents they just don't know what to do when they're working with a teenager, even though they love them and accept them. So this is a big piece of the puzzle, I think, that's understudied and under-recognized. And there's a great book that was published last year called Far From the Tree by a guy named Andrew Solomon. He's at Cornell. And the premise of the book is what do parents do when their children are very, very different from them. When they're gay, when they're transgender, when they are deaf, or when they're prodigies. What do parents do? They don't have the same kind of vertical cultural identities like race and ethnicity and gender that they can use to help learn, to help teach their child how to navigate the world. And it's the same for gays. All right, so these are the 3 major sort of research milestones that we like to think of accomplishing when we're trying to reduce health disparities in a population, right? So we want to detect first, see if we can detect them. Are they there? Then we want to see what's causing them, understanding what's driving them, and then figure out a plan for reducing health disparities, right? So I'm going to talk about detecting mental health and substance use disparities in gay youth first. We published 4 meta-analyses over the last 5 years on these 4 topics. I'm going to talk about 3 of the 4. And let's just jump right in for the sake of time. Substance use disparities in gay youth are really high. So this number means that gay youth, on average, using these 18 studies that we pulled from the literature, we took out their data out of their papers, and we put it into a meta-analysis, and we did this fancy data analysis, and we came up with this average difference. So this means that gay youth are almost 3 times more likely to report a history of substance use. This is all cross-sectional data. It was published in 2008, and there were 18 studies published at the time that we were able to use for the analysis. This was a surprise to us. This disparity is bigger for girls. So in other words, sexual minority girls, lesbian and bisexual girls, compared to straight girls, are 5 times more likely to report a history of substance use. It's much smaller for boys. It's significant for boys, but it's much smaller for boys. There's a girls theme running through here I'd like you to pay attention to if you could. And then this is another theme. Remember that curvilinear model I showed you at the beginning? Bisexual youth report almost 4.5 times more likelihood of using substances compared with hetero youth. The number is much smaller for folks who identify as lesbian or gay as opposed to bisexual. So moving right along to suicidality. The next meta-analysis that I'm going to present to you is describing rates of suicide and depression disparities among gay youth. This is the most common. These are the most common ways of operationalizing suicidality. It's kind of on a continuum. You know, we start with some people have just thoughts of suicide, but they would never actually do anything about it. Some people have plans or intent. They've decided that they're going to jump off a bridge on Saturday night, and they've written a note to their parents. Some people have actually made an attempt, right? So this is severity of suicidality as we go down the scale. And some folks have made serious attempts that would require medical attention. So for this analysis, all of those are merged together. So this really could just be interpreted as risk for any level of suicidality. So gay youth are almost 3 times more likely, on average, to report histories of suicidality. And this is very high for bisexual people. I wonder why. If you think about why, we'll talk about it towards the end if you like. Why are bisexual people at such high risk? I want to pause here for a minute and say something that's a little bit of a tangent, but so bear with me. But I want to put these numbers in context. So my aunt is a 2-time breast cancer survivor, and her mother, my grandmother, was a 2-time breast cancer survivor. And my father died of bone marrow cancer 12 years ago. So I'm very familiar with cancer treatment, and the struggles that go along with it. So what I'm about to say isn't meant to be insensitive to folks who have similar experiences. But I was reading the New York Times several months ago, and they highlighted a study, the front page of the New York Times. And the study was about women who drank moderate amounts of alcohol. Women who drank 5 to 7 drinks a week were, on average, more likely to develop breast cancer or a higher risk for breast cancer than women who did not drink 5 to 7 drinks a week. And the odds ratio was, the number was 28% more likely. So that's an odds ratio of 1.28. So this made the front page of the New York Times. Yet, when people report gay youth being 5 times more likely, not an odds ratio of 1.28, but we're talking almost 5, 4.92, of making a serious suicide attempt. And it's not being covered in the news. It's a little disheartening. A lot needs to be done to raise awareness of the issue. So these studies, 13 of the 19 studies in the suicide meta-analysis reported the actual rates of suicidality. So we could come up with these rough estimates. 28% of gay youth, SNY stands for sexual minority. 28% of gay youth report a history of suicidality compared with 12% in heterosexual. So that's a pretty big difference. And there's a few other studies that have come out recently that have shown similar numbers. A guy named Hassan Bueller published a study of Oregon State with statewide high school data showing that gay youth were 24% of gay youth reported having made a suicide attempt. So his numbers are actually a little bit more severe than ours. So what about this 10% rule? If we use this 10% rule, and we have 2.5 million gay youth in the United States, we can estimate that almost 750,000 youth, gay youth, who are at risk for suicide in the United States. Even if our numbers are off by 5 or 10%, we're still talking anywhere from 500,000 to 1 million kids, and that's a big number. What we also find that I thought was quite interesting was that the difference between gay and straight youth in terms of suicidality increased as the severity of suicidality increased. So gay youth were 2 times more likely to report ideation, 3 times more likely to report an attempt, but over 4 times more likely to report a serious attempt, which is kind of scary. So So what comes after a serious attempt on the scale? Completion. And doing studies on history of folks who have completed suicide are difficult, fraught with methodological problems, because once someone is dead, you can't really interview them to find out why they were suicidal. So we really don't have those good numbers, but if we use this as a guide, I think we could safely say that we'd be over 4 times more likely to complete suicide. It's a very, very uplifting talk, isn't it? Okay, whatever. Computer's not listening to me.
Same thing to me yesterday.
Did it?
Yeah. Go back to the,
Should I hit escape?
no, go back to your original file.
It won't let me get out of it.
Okay. Let's see.
Should I just... Thank you. So these huge disparities are very, very troubling. But none of the studies in those meta-analyses were from Pennsylvania. And I'm just kind of curious, do we find the same pattern of results in the autism kids in Pennsylvania? And what about Pittsburgh? Well, I was lucky enough to convince the Pittsburgh Girls Study to add a measure of sexual orientation to their battery, and then I wrote a grant, and NIDA's funding this grant to study this group of girls. The Pittsburgh Girls Study is great because 10 years ago, they recruited 2,400 girls from Pittsburgh city proper, door to door, ages 5 through 8, and interviewed them every year for 10 years up until now. So we have 10 years of longitudinal data on 2,400 girls. And then we added sexual orientation to the last interview. So now we can look to see whether or not same-sex attracted or sexual minority girls are different in terms of their health profiles with this huge data set. It's hard to get data sets like this. And what we're finding is that all of the results from the Pittsburgh Girls Study data, pretty much replicate what we find with the national data. Over 2 times more likely to report cigarette use, marijuana use, 3.5 times more likely to report smoking weed. This final one is extremely disturbing. Non-suicidal self-harm, like cutting behaviors. Oftentimes teenagers will cut themselves or burn themselves as an emotion regulation tool when they're really in high levels of emotional distress. 7 times more likely to engage in non-suicidal self-harm. These are girls in our backyards. These are girls that come into our clinics, and girls who go to PIT probably in the next few years. So this is a local problem as well as a bigger national and world problem. So the more we can do locally, locally to don't worry, I won't talk for 4 hours. Now, what we can do locally to help support the community and to help reduce these disparities is really, really important, as you can see. Local policy is important. So the next thing we did was we wanted to see whether or not just only, when we take a snapshot of kids, we just hand out a questionnaire to all the kids in Pittsburgh high school, all the high schools in Pittsburgh, and we ask them to answer a questionnaire, and we have one single time point data snapshot of what's going on in their lives, right? These are teenagers on a mean age of like 16. Well, if we followed teenagers over time into young adulthood, what would we find? Did those disparities disappear? I mean, there's this huge national campaign out there, which I love, by the way, called It Gets Better. I love the It Gets Better campaign. I love the slogan. The slogan is 3 simple words to convey to gay youth at one. It's not so good right now. So when you hear it gets better, it's kind of validating. You say, yeah, it kind of sucks right now. But also, it's hopeful, which I like a lot. So we have good reasons to believe that the stressors that the LGBT community faced in adolescence probably persisted in the young adult. I mean, it changed a little bit. So when you get older and you're in young adulthood, you're not allowed to so that can be a stressor. It used to be, before the Don't Ask, Don't Tell was wiped out, folks couldn't safely and comfortably join the armed services. Probably still can't. I'm not sure one would be willing to, knowing the history of the culture of the armed forces. There's evidence of workplace discrimination, including hiring discrimination. I found one study, I think it was mostly young adults who were respondents in this study, where they took two identical resumes. This is probably like in schools of business. And they gave them to business students. And the resumes were identical in every way, except on one, the applicant for the job was, say, president of the local YMCA club. And on the other one, it was president of the local LGBT community center. That's the only difference in these two resumes. You randomly distribute them to respondents, and guess what? Resumes where there had any information about being a member or participating in the LGBT community were rated as being less favorable applicants. So there is hiring discrimination, there's workplace discrimination, and it goes all the way into the later on. So it's really difficult to do longitudinal research with gay youth because we want to know what's happening in adolescence and whether or not that continues into young adulthood. But to do that, we need to recruit gay youth in adolescence. And so we could put up a sign that says, hey, we're doing a gay youth study, come and sign up. And by the way, bring your parents, because we need your parents' consent to join the study. Well, no one's going to come because most gay youth are not up to this. So we've had to resort to other resources to conduct these analyses, at least for now. And one way to do that is there's two data sets that I know of in existence that have longitudinal data with a very big sample of youth lasting into young adulthood, with information about sexual orientation and information about depression, suicidality, and substance use, the kinds of things that we want to know about in terms of disparities over time in young adulthood. Two in the whole world, maybe, I don't know. We were able to use one of them to conduct some analyses to test this hypothesis. Do the disparities last in adulthood? It's the Ad Health study. 20,000 kids recruited back in the mid-90s out of high schools to be a nationally representative sample of high schoolers. And then they interviewed them 3 more times up until about 12 years later when they were in young adulthood. And this is the data set we used. Just briefly put on your thinking cap for just a second. I'm going to fly through a longitudinal statistical tutorial. But it's pretty easy. So, but I'm going to fly through it. Imagine this is me, and these are my reports of drinking in the past year. How frequently did I drink over the past year? And I answered for year 1, year 2, and year 3. And as a teenager, as I get closer to 18, my drinking is going to go up. That's usually what happens. And imagine if I fit a best fitting line to that, those set of points, right? That line is really helpful because it says where I started, where I finished, but also at what pace did I increase my use over time. So imagine if we did that for a couple of hundred kids. So we have an estimated line of change over time in behavior, like substance use. And then we can take the mean of the whole sample and say, well, on average, where did kids start and how fast did their substance use increase over time? Guess what? We can also do it for more than one group. We can estimate these trajectories for whoever we want and look at them however we want. So imagine this is the average trajectories for boys and girls, right? Or parents or children of alcoholics and children of non-alcoholics, or white Caucasian youth and African American youth, or gay and straight. And that's what we did. We stratified our trajectories of suicidality and depression by one's sexual orientation. And just to get right to the punchline, here is a sample of our results that were just accepted yesterday. yesterday to be published in an adolescent journal, which I'm thrilled about. The top group is bisexual youth, consistent with what we know from the cross-sectional studies. The second group is mostly heterosexual. And when people endorse this mostly heterosexual label, they say, I'm mostly heterosexual, but I'm a little bit attracted to members of the same sex. So there's some same-sex attraction. They're not 100% straight. And these are the 100% straight kids. And these are depression symptoms. And this is the mean age at weight 1, and the mean age down there at the final weight. There were 4 time points. And as you can see, the disparities we saw in adolescence don't get better. They persist into young adulthood. So that's trouble. So what do we find for suicidality over time? This is the same sort of general scale that I described to you earlier. And this is what we found with suicidality responses from these young adults. The top group, the bisexual group, yet again, we were way up there compared to the other groups in terms of risk for suicidality in adolescents. And all 3 of these sexual minority groups at the top decrease over time, as does the hetero group. This is a normative thing. Teenagers are higher risk for suicidality, but as they get older, those suicidal thoughts and feelings sort of dissipate over time. At all of these time points, gay youths were still significantly higher in terms of their rates of suicidality, all the way into time 4. So even though it looks like they got closer, perhaps to the point where they're equal, they're not. Even down there at the end, there's a significantly higher rates of suicidality among male LGBT or LGBT kids. This slide kind of suggests that it does get better. And so this is partly why I'm hopeful and supportive of the It Gets Better campaign. Because after all, it's a campaign that was mostly focused on reducing suicide among gay youth. And they're right. It does get better. And for bisexual, we think it's dramatically better. So their message is partly true. And that's encouraging. Okay, so how do we understand disparities? One thing we can do is just look to see whether or not our hypothesized mediators or risk factors, the things that we think are causing them, like gay-related stress, stressful conditions, violence and victimization experiences, are they higher among gay and lesbian teens? So we conducted this meta-analysis, once again. We published it in the American Journal of Public Health, so it's a top-tier public health journal. And we looked at 4 outcomes, but I'm only going to present 2 of them here. The 2 outcomes we were looking at were whether or not kids endorsed being threatened or injured with a weapon or otherwise assaulted by a peer at school. So that sounds pretty serious. We don't know what assaulted means, but we're talking about violence. And the next outcome we looked at was simply whether or not the kids skipped school or missed school due to fear. So indeed, the results kind of confirmed our hypotheses that gay youth were at much higher risk for being assaulted by peers at school with a weapon, almost 3 times more likely. And this was higher for girls, which is something we also didn't expect. And you know, a lot of folks now are saying, oh, you know, it's kind of cool to be a lesbian in high school. You can hold hands with your girlfriend, you can kiss, there's not too much discrimination. I hear this from kids sometimes, I hear it from wishful thinking teachers and parents. I hope that they're right, and in some pockets of the world, they probably are right. But on average, what we're finding is that girls experience, sexual minority girls experience larger disparities in being assaulted than do boys. So maybe it's not so easy to be a lesbian or a bisexual or a young woman in high schools. And so, 2 things I'd like to highlight here. So up here, this is a scary number. 50% of gay young men, or boys and young men, have been assaulted at school at some point in school career. That's a big number. And the gender disparity I want to point out here is, here's heterosexual girls, here's bisexual girls and lesbian girls. So as you can see, the disparities between these two groups and this one is bigger than it is between these guys and the boys. So there's a bigger gap, there's a bigger disparity, but actually the absolute rates of experiencing violent victimization in schools is highest among boys. Missing school due to fear, we found very similar results, almost 4 times more likely. And this was a bigger effect for kids who identify as bisexual. And here's the point. So another way we can try to figure out how to explain what's going on, what's driving the disparities, you know, we can see that there's major differences between groups in one of our hypothesized explanatory variables, violent victimization experiences and discrimination. But we can also estimate these, what we call mediator models. So sexual orientation is our predictor, we have our outcomes, and then we put in our mediator model to see whether or not it basically accounts for that association statistically. I won't go into too much detail, but notice that this statistical pathway that we have built is the same as this. It's the theory, right? Minority status, sexual orientation, gay-related stress, and outcomes. And we did that purposely because right now there's only 2, now there's 5 because we've just recently published 2 studies showing gay-related victimization as a mediator. Prior to that, there was only a couple of studies that had actually shown any kind of evidence for this model. So that's what we did, and indeed we found that gay-related victimization experiences accounted for a significant part of the reason why gay youth were depressed and suicidal. Okay, so we think we know a little bit about why gay youth have higher levels of stress and mental health problems and substances. How many studies out there would you say have conducted, you know, sort of interventions for gay youth with like, you know, like rigorous scientific interventions to try to see whether or not there's any kind of intervention program that can reduce disparities? How many would you say are out there right now, published in the literature? Any guesses?
Half dozen.
Sorry?
Half dozen.
Half a dozen? I like that. I like that optimism.
But you know, I'm going 3.
You can say 3?
I would say 3.
It's 0. The answer is 0.
Even anti-bullying?
There are anti-bullying programs out there. That's a really good point. And some of them do now finally have some sort of gay-related components to it. But usually they're a small piece of the bigger bullying program. And no one has ever looked to see whether that small piece reduced gay-related bullying in schools. So there's no science to back it up. But there are some anti-bullying programs out there that include it. We just don't know if they work. So I'm going to stick my neck out here a little bit and say one of the biggest health equity interventions in the history of the United States happened in 1964. Anybody guess what that was? Civil Rights Act. Right? Civil Rights Act. So that was a policy level decision to try to improve conditions so that a minority group or multiple minority groups had equal rights, which we would hope would reduce the health disparities that we saw back in, say, in the African American community. And I'm sure that it did. Are there still health equity problems in the African American community? You bet. So that was 50 years ago. There was a congressionally approved, presidentially approved law that was put into place to change American culture, to impose and provide equal rights for minority groups. And even today, we're not seeing the full effects of it yet. Hopefully There's a lot more work to be done. So when the major stressor, or when the major cause of a disparity is a societal level cause, how do we change that? We have to change it through reducing the societal level toxins. So maybe through policy. In some policies, we're working hard on trying to generate the data so we can start changing policy. And 2 of our meta-analyses were taken by the minority stress model that I showed. Elon Meyer is the author of that study, and he emailed me once back in 2011 and said, hey, I heard you just published these meta-analyses. Can I take them down to DC and report your results to this U.S. Civil Rights Commission hearing in New York to help reduce bullying among gay youth? I said, of course. And he did, and that was quite an honor. But I think that's what we have to do. And we're not quite there yet. So other things that we can do is we can try to figure out what are the things that gay youth that are happening for a particular gay kid that we can help change or reduce or improve to make their lives better. So the stress, gay-related stress, doesn't have such a big impact on them. So these are 3 potential mediated pathways that we were proposing that we just got a good score on from NIH or NIDA, and we're hoping they're going to fund this to try to look to see whether or not, if we can reduce depression, negative affect, responses to gay-related stress, that we can help kids cope with the stress, maybe that will reduce the long-term outcomes. If we can help kids feel less marginalized when they're pushed out of mainstream peer groups because they're homophobic or violent, can we help promote hope for the future? And we actually have some data to support all 3 of these mediated pathways. Two papers that are recently been published. And we think that might be another way to go. If we can't change policy, we can at least help the kids cope. So these are the conclusions. There are large disparities, as you have seen, for gay youth. For some gay youth, the disparities last well into young adulthood. And there's heterogeneity within the LGBT group. So in other words, for some outcomes, girls are at higher risk. And for some outcomes, bisexual youth are at higher risk. So we can't just lump all kids under one umbrella and expect that we're going to know what we need to know to conduct a good intervention. We need to understand the nuances and the differences between individuals within the LGBT community. So we have good reasons to be hopeful. I like to end on a happier note. There are many long faces out there. It's depressing talking about all the bad stuff. So 72% of gay youth aren't reporting suicide out, which is pretty amazing, given all the stressors that they face. And who are these folks, and how can we learn from them? What are they doing? What kind of resources do they have that we can learn from, so we can design intervention programs to help other kids get to the place where they are? There's been a lot of change lately at the government level. Thankfully, thanks, Paul. Thankfully, since the Obama administration, there's been some big changes at the government level in terms of promoting awareness of the issues and promoting science and understanding of what's going on. So this is the first governmental report of its kind using CDC data, because they have tons of it and they've been sitting on it for a long time. They had youth risk behavior surveillance data from 10 to 12 states that they combined all into one huge data set, 30,000, 40,000 kids total, with 2,000, 3,000, 4,000 gay youth. And they wrote up a report to describe what the disparities were and what needed to be done next. So you can go to the CDC website and get that. I think it's free. I think everything on there is free. We were pleased to see that their results pretty much validated or replicated all of our meta-analysis findings, so there's some consensus across research groups. I don't know if any of you have heard of Health People 2020. But this Healthy People campaign was started like 50 or 60 years ago. They issue a report, the federal government issues a report every 10 years on the status of American health. And so there was a Healthy People 1990, 2000, 2010, 2020. It wasn't until this one, 2020, released 2 years ago, that the federal government included LGBT populations as a noteworthy group of needing to understand more about why there are these big disparities in health problems. 10 years ago, the LGBT community created their own Healthy People document and gave it to the Healthy People, 10 people, said, here's ours, in case you want to know what we think. And then this year they decided to include it, so that was good. And then the Institute of Medicine, the National Institutes of Health gave the Institute of Medicine a bunch of money to write up this report on the status of LGBT health in America. That came out 2 years ago as well. And so, for some reason, this kind of governmental activity and interest in these issues didn't happen in 2000 to 2008. I'm not sure why. I don't know if President Bush was interested or not, but President Obama certainly has been. And so has his Secretary of Health. And Secretary Sebelius has been actively involved in promoting the understanding and the health of LGBT populations. She's been a big supporter. And finally, the government has this stopbullying.gov page. And they have taken the tact of including LGBT populations in this bullying website page to raise awareness of the issues. So that's all good news. Change is happening. We'd like to think that it will happen faster over the next 10 years, but we're making progress. And if you guys are interested in local resources, there's a bunch of them there, and many of you already know what these are. These are local resources. I see LGBT kids for psychotherapy in the adolescent medicine clinic. And we also have what we call a gender clinic. We are now working with transgender youth or genderqueer youth to help them and their families make the transition if they're interested in transitioning to another gender. And so we have a gender clinic there, and we're working in collaboration with the endocrinology clinic at Children's Hospital. And that's been good. We have 10 to 20 kids now, approximately, who are working with us at various stages of gender transition. It's been great, and we've recently had some media interest, and we're going to do a feature story on the fact that we posted that one of these days. And that's it. So I want to end on a happy note.
Disparity between heterosexual girls and gay, lesbian females, and I was wondering to what degree whatever girls are going through in just the rates of depression and internalizing that kind of a women, boys tend to like externalize whatever it is, the distress and women tend to internalize. So how much has been done to kind of figure out what's happening with that and this kind of self-harm tendencies?
That's a great question. I like your description of externalizing and voicing. There's some evidence for that. Actually, among girls too, the boys and girls are reporting higher rates of, say, for example, conduct disorder. That's really a sort of rebellion that this goes against sort of the homophobic society. So that paper that we just published, I put in the discussion of that paper a hypothesis. I'm not so sure if I'm on target. No research has been done to try to understand why girls might have higher rates or larger disparities, especially in substance use. But one of my hypotheses was that there's a theory out there about why young girls and young women are at higher risk for depression and suicidality in their teenage years. And it's actually a Department of Psychiatry faculty member who wrote this great paper years ago, cited 500 or 600 times, describing how for girls, we think that there's, the term she used was, they have stronger affiliative needs. So girls are much more social. And being embedded in a social network of other girls and kids and feeling connected to them is a big part of girls' identities. And so if sexual minority girls have a sort of higher need to be affiliated with peers and be networked in, but they're also experiencing violence from that same group, perhaps they're internalizing it even more than boys do. So boys might say, oh, well, you know, pardon my French, F you guys, you know, if you're going to call me bad, I'll just go find some other friends. But girls might internalize it and hold on to it longer. Just one of a few hypotheses. But it's, I would be willing to bet that it has a lot to do with socialization of girls and girl culture during the teenagers. Maybe. I would love to hear your thoughts if you have any other ideas, please send them.
I just because I'm right now interested in studying, like, looking at smoking, so I was just trying to understand why girls smoke cigarette, and I was trying to understand why is it that boys act out. Like, I think it seems to me like a female can go have a lot of problems for quite a long time. If you're just hurting yourself, if you're hurting yourself using a knife, you're going to get attention of, you're going to get help sooner. So I'm wondering also how much that plays into it. I mean, if you are hurting other people, the police will be there, somebody's going to, you know, reach out somewhere other. But if it's it can go, you know, undetected for a very long time.
Right. I have a lot of kids in my clinic who had a history of self-harm for that very reason. That's tough. Any other questions? Yeah.
The other question I had is the question you asked about attraction. Is that like pretty much, is that becoming a standard in pediatric adolescent clinics? Or is it just Pittsburgh? And was that from the children's hospital? Are all like kind of like community practices asking the same question?
They're definitely not asking the same questions. In fact, even most adult clinics don't ask about sexual orientation. And luckily, UPMC is on the case. They've formulated a couple of different working groups, and the Center for Inclusion at UPMC Human Resources has started a UPMC-wide needs assessment of LGBT cultural competency training in the UPMC clinic. So UPMC is the Western PA's largest employer, 55,000 employees, hundreds of clinics, thousands of doctors, but very, very little history of training in LGBT issues. And they've embarked on a campaign to change that slowly over time. I think the adolescent medicine clinic is quite cutting edge. And I think adolescent medicine clinics in general are cutting edge when it comes to facing the realities that adolescents bring to the table. So, you know, I didn't know this before working in the adolescent clinic, but medical doctors can specialize in adolescent medicine specifically. There's only a couple of hundred boarded adolescent medicine docs in the country, and there's a couple of dozen adolescent medicine clinics in the country. And I would guess that most of them ask about sexual orientation regularly with all the kids, because it's a big part of the kids' experience. And I think that those clinics are just more grounded and are better in tune with what the day-to-day lives of adolescents. So by default, they kind of have to, if they want to do their jobs well, they have to ask about all of these things. Attraction is the most common way to ask the question. But if we have someone in the clinic who we feel might be at high risk for, say, contracting HIV, so if it's a young man who says, yes, I'm attracted to boys, the clinician will most likely follow up with, well, are you having sexual relationships with other boys? And if yes, are you using protection? And if no, have you had an HIV test? So that takes him down a particular path in terms of clinical interviewing that hopefully helps keep the kids safe. So it's part of a bigger plan, you know, to help all kids be safe in the clinic. Did you have a question?
Yeah. How do the rates of depression and suicidality for transgender youth compare to the other groups?
Oh, I'm glad you asked that. So there's the meta-analyses that you guys saw. up here that we used to do the meta-analysis, there was probably, by now there's probably 2 to 3 dozen studies in the literature that compare gay youth to straight youth. And they're all cross-sectional, just single time point, right? 2 to 3 dozen. How many studies do you think out there compare trans youth to non-trans youth?
I'm guessing 0.
0. Not one single study. So we know very, very, very little about the transgender youth population. We've started collecting data, and next week there's a transgender health conference in Philadelphia. So if you Google Philly Trans Health, it'll be your first hit. And it's been an ongoing conference for about 11 years now. This will be the 12th year. And last year there were 2,000 conference registrants. And it's just a fantastic conference to go to. I'm going next week, and I'm presenting data at the conference from our little pilot study. We have about 20 youth who are identifying as either transgender or gender questioning, meaning they're not really sure what their gender identity is, and finding similar rates of disparities when we compare trans youth to non-trans youth. But we're talking small numbers. Our sample size is an N of 20 compared to about 100 non-trans youth. But it's a start. And we're hoping eventually to publish it and get it on the map, and hopefully other people will follow suit. I know there's 2 or 3 clinics around the country who probably have enough trans youth to do a better job and have a bigger sample and a better study than I have. They're more focused on clinical care, so they haven't taken the time to do it, but eventually it's going to start happening. And then you were asking about into young adulthood. There is one of the leaders in the transgender health adult research literature is a guy named Walter Bockting, B-O-C-K-T-I-N-G, and he has a big federally funded study to recruit transgender adults on Facebook. And I think he's gathered a population or a group sample of several hundred, maybe over 1,000. I don't think he has a comparison group, but he is starting to publish papers that describes, sort of the health profiles of this large sample of transgender adults, which I don't think has ever been done before. So that might be a resource. So thank you. I think time's up. Happy to answer any questions if you guys want to talk more.
First question, I did not get your slides.
Yeah, I left them on the machine.